we are only like 35 minutes behind. You know, that's all good. It's all good. I want to reassure the keynotes that you will have your full time allotted because we want to hear all about the amazing work that you're doing. So moving on, it's really my pleasure to welcome, can I say Dr. Karli Swenson? So Dr. Swenson, she's a program assistant at the Colorado Perinatal Care Quality Collaborative, and she just received her PhD in physiology. And so her PhD was in cannabis and CBD usage in pregnancy. And if that's not enough, she is soon to complete her master's in public health in MCH, maternal and child health. And she has applied to medical school. So I have no doubt that she'll be starting in medical school in the fall. And she's been with CPCQC working on the COAIM-SUD initiative to improve substance use screening, brief intervention, and referral. And importantly, she's been doing some very impactful work around addressing stigma and bias among healthcare providers. So I'll have her share a bit of her work and then introduce our lived experience experts. Thank you.
All right. Let's see. There we go. Hi, everybody. I'm the only thing holding you between now and meeting our lived experience experts, so I'll try to be snappy with it. But what we're going to talk about now is the experiences of people who have substance use disorders when they go into the hospital. Let's see if this goes forward. Yes, it does. Like Susan said, my name is Karli Swenson. I'm a program assistant with CPCQC, and I've been working a lot in the stigma and bias world recently to improve care for these patients. So I have no disclosures. So as we've heard today, accidental overdose is the second leading cause of death for pregnant and postpartum people in Colorado, but we want to know what their experiences look like. And we understand from many reports of what patients say that their experiences were, but we wanted to understand it from a healthcare provider perspective. So what we've been doing for the past couple of years, we've been administering surveys to nurses in labor and delivery units across the state of Colorado and asking what changes in their colleagues' attitudes and behaviors when patients disclose substance use or if they perceive that their patients are using substances. And we also ask about the patient's mental health. This is just some of the respondents for the 2022 cohort. The main takeaway here is that the majority of our respondents had a bachelor's of science in nursing and were registered nurses. We captured a wide variety of experience in nursing, ranging from new grads to 25 years and up in nursing. The majority of people had been at their current facility for more than 5 years. So this lets us know that we're capturing a pretty good representation of the culture on a unit when these nurses have been at their institutions for a while. And 78-ish% reported not having experience in a substance use setting, despite accidental overdose being such a leading cause of death. 97% of respondents on our survey said that the attitude of a nurse either slightly or significantly impacts the care that that patient receives. And the reason that we ask about this before going into asking what their attitudes and behaviors look like, we want to characterize that we know whether your attitude is good or your attitude is bad, that directly impacts the care that the patient receives. And the nurses acknowledge this. Okay, you'll see a couple graphs that look like this, so I'll walk you through it. What this graph is showing is how the nurse's attitude changes in response to a patient with perinatal substance use. The top bar is if they perceive that the patient has been using substances. The bottom bar is if the patient discloses that they're using substances. And we ask specifically, not about their own attitudes and behaviors, but about their colleagues' attitudes and behaviors, because people might not want to self-report negative attitudes, but they might be a little more honest about their colleagues. And what we see here is they were pretty honest. We're just about 64% in that disclosure block said that there's either a slight or significant negative impact on the attitude towards the patient. And when we look at behavior, luckily it's lower, but it's still pretty high. Between 30 and 40% are saying that there's a negative impact on behavior, whether the patient discloses substance use or the nurse perceives that they've been using substances. So just taking a second to think about that, that is a pretty massive impact on patient care that we are seeing. And this graph is a little different. On the bottom is that 2022 data I just showed you with the 64%. We repeated the survey in 2023 after these hospital teams had been involved with COAM SUD for a year, and we had a 10% decrease. That's awesome. We love a 10% decrease. But above 50% still having negative attitude and behavior shows that we really have a lot of work that we can be doing in this space. And now I want to walk you through a few of the qualitative responses. So we got their answers saying that their colleagues report negative attitudes, negative behaviors, but what does that actually look like? Interestingly, because only 5% of people said that positive change happens, but 47% of our, can you give us an example of a change? We're all positive examples. So I think that shows that it's easy for us to say, no, we're doing good. Some of the reports of positive changes were that nurses value the patient's honesty, which makes sense, that they're able to provide resources. Sometimes they said that they appreciate seeing that the patient is trying their best to recover. They're able to encourage that patient in their recovery. They're being more aware to ask questions and to monitor that patient closely. And I thought this was one of the most interesting responses, actually. Maybe. Okay, there we go. So the other, about half of the responses gave us examples of those negative attitudes and behaviors. And this is really like the meat and potatoes of what we're working with. And we want to give some examples. So this is, if you've seen me talk before, this is the quote I like to use. I think it really encompasses the majority of the responses that we got, which was this nurse said, "I've witnessed this with my colleagues and even in myself, when all you want to do is the bare minimum for these patients and not want to get them the added support or help they may need or even deserve." I appreciate this nurse's honesty. That's a vulnerable thing to say, especially when you want to be providing the best care you can. We're acknowledging that there is a failing in the system, which is important. Okay. This is a little bit, keep in mind, we're surveying labor and delivery nurses, but we actually captured quite a few responses from the postpartum period with infants. So I'm going to give you a little bit about what we see in L&D, which is a little less applicable to you, but to know what your patient, or the mother of your patient, I guess, has gone through before she interacts with you. We got reports of denying pain medication. Many, many reports of denying pain medication. Not believing that the patient is in pain, calling the patient drug seeking. We got people reporting that the patient was on Subutex or buprenorphine, so that's taking care of their pain, which it's not in labor and delivery. Calling the patient difficult to work with, calling the patient a drug addict, blatantly. And multiple reports of them assuming that the patient has no coping skills because they reported substance use in their own pregnancy. And a general a negative attitude towards both the patient and the patient's family. Okay. This one is also an important theme that we got. Of the people we've spoken to, we get a lot of, I'm sure that this is a pervasive attitude, but not at my institution. It doesn't happen here. We are great. One report said, "Ethnicity has never been an issue in our unit and it never will be. We accept and treat all patients despite their background. I do not feel it is wise for us to look at the opinions to base whether or not someone is being treated appropriately. I think we are working too hard to make race an issue in places it isn't." And from the same group of respondents, we got this report saying, "Sometimes patients who are abusing drugs will have an attitude and mistreat nurses and be uncooperative. Some are Native Americans who have a clear disdain for white people, which complicates the nurse's plan of care." I think that these two answers were quite literally next to each other in the form, which kind of shows this is happening at our institutions. I know we all like to have the best view of the place that we work at. It makes sense, but I want you to know how pervasive these attitudes are. Some of the stigmatizing language, we only see the patient for 4 days. We're not going to be fixing a drug abuser. We don't expect you to be fixing anyone, but we certainly can provide appropriate and if not exemplary clinical care to these patients. Okay, so the patient has gone through her whole pregnancy. She's gone into L&D. Likely she's been treated poorly in L&D, unfortunately. And someone's calling me in the middle of the talk. That's rude. Sorry. Now the baby's delivered. Maybe the baby gets moved into the NICU and you are now involved. So we want to talk about how patients with substance use disorders are now treated in the NICU. One respondent from L&D said that one of her colleagues over in NICU made an assumption that the patient didn't care about her baby because she used substances during pregnancy. We got reports of not assisting the mother in bonding when you assume that the baby is going to be taken by CPS. This one said the mother of the child was with the baby in the NICU, that they had a history of substance use but had been clean for 10 years. She was not allowed to feed the baby and at the breast pump or milk until the cord blood was negative. And she insisted it would be negative. It was negative. And I feel like she was profiled by the MDs due to her past. So this person had been in recovery for 10 years and wasn't allowed to feed her baby. We got multiple reports of gossiping about the patient. Most commonly, the reports were at the nurse's station gossiping about the patient. And I think we all know that those doors are thinner than we think they are. And patients can hear what is being said outside the door. Not only your patient, but the other patients on the unit can all hear what is being said. And so this is just one example, but many times when a pregnant woman comes in under the influence, I hear colleagues comment on how could someone do that to their baby, or hopefully CPS will just take that baby. And so if you are the mom in that room and you hear your nurse who just came in and put a big smile on her face and tried to work with you, and then she goes outside the room and you hear her talking to her friends saying, I hope that they take that baby away. What a horrible, traumatizing experience. This one is long, but I'll read it. This person said, I was receiving a report from a day shift nurse for the patient who had a history of substance use. The nurse spoke to the patient in a very short and condescending way. And the patient later told me that the nurse had discussed her substance issues in front of the patient's visitor, her mother, who is not aware of the patient's struggles with substances. The patient said that this information was shared in front of the mother and it caused significant issues between her, the patient, and the patient's mother. This is one of those situations where we need to understand that substance use is a medical condition. And before we verbalize that to visitors, we need to talk to the patient and understand who knows what. This is a sensitive topic before we just go talking about it in front of visitors. And this is the longest quote of the day, and I apologize, but I really think it's important. This person said, I've observed the way the majority of my coworkers interact and speak about our patients with substance use issues, and it's absolutely awful. These mothers especially are not spoken to with compassion or in a trauma-informed manner, and I've seen at least one incident of a blatant disregard for a patient's confidentiality. Nurses are horribly undertrained in therapeutic, non-stigmatizing communication and understand very little about substance use disorders, and it has a huge impact on their quality of care. My professional background before becoming an RN is in addiction recovery services, and as a nurse, it's heartbreaking to see that these patients' care is subpar for their condition and their circumstances during such an incredibly vulnerable and stressful life event. I had a traumatic postpartum experience myself, and I know firsthand that having a truly compassionate, knowledgeable, non-judgmental carer will make an incredible difference on the patient's well-being. We need to do better. And that one really encompassed the acknowledging where we're at and acknowledging the growth that we can have to improve care for these patients. And we know that persistent stigma harms patients and discourages from seeking care. We know that you all take care of the babies, but in that dyad, we want that baby to have the best interaction with their parent that we can. I think we all agree on that. So by decreasing these horrible experiences that these mothers and these parents are having in the NICU, will set them up to enjoy their interactions with healthcare providers more. They may be more likely to attend their postpartum appointment. They may be more likely to attend their infants' later pediatric appointments if we make this a positive experience. A little bit of education on stigmatizing language. And these are things we hear all across the units. I've heard it on this campus when we refer to patients as an addict. We talk about their drug habit. For patients who are in recovery, we might say that they've been clean for 5 years, 10 years. But the inference when you say clean is that those who use are dirty. And that's not a very polite way to refer to someone who's struggling. A clean drug screen or a dirty drug screen goes in that same realm. Calling them a reformed addict, saying that they're in detox. These are all things with just the slight shift of language, we can improve the experience that this patient has. I see a lot of people taking photos and I'm so excited. Please do if you want some reminders of some simple switches that we can make. Okay, I'll let people take that while I introduce the next slide. So I've showed you persistent stigma and bias, negative attitudes, negative behaviors towards patients, right? So this takes us into what do we do about that? I didn't show you the slide on how many nurses reported wanting training. So many nurses said, I've never had education on this. Not in nursing school, not in undergrad, not in continuing education. I've never had to take a lesson on it in my current job. I've never been trained on this. What do I do? So what we're doing, we're currently piloting it with L&D nurses right now and kind of doubled our registration from what we anticipated, but it's been going really well. Is a perinatal substance use stigma and bias training for nurses. Please, if you're interested, fill out this QR code. It takes you to an interest form for us to expand this pilot initiative, especially to expand it to specific audiences like a NICU audience. We need to know that people are interested. So if you are, please fill this out. Some people are taking it voluntarily. Some hospital systems are now making it mandatory for their nurses. So if you're in a position in your hospital that this is something you could have a say in, please come talk to me later. And with that, let's go ahead and introduce our HardBeauty folks. There they are. Come on up. Okay, and we're going to talk to some lived experience experts. Oh, do you guys have chairs? That one? Yeah. Maybe. There we go. Okay. Here's a mic for you.
Brett come up here with us.
Okay. Oh, sure. Why not? I'll take the mic. Is that working? Yes, it is. Okay. So these are our incredible speakers from HardBeauty. These wonderful women are here to tell us their stories and to be vulnerable. And with that, I want people to feel comfortable asking questions, but also acknowledge that these are sensitive topics and to appreciate their time and their honesty and their willingness to come educate us all on what we need to know. If you two want to introduce yourselves, we can get into the questions.
Hi, everyone. Thanks for your time and energy today. I'm Tiffany Cuvede. I am a mom in long-term recovery, and I'm the Director of Coaching and Unbroken at HardBeauty.
Hi, everyone. My name is Raquel Garcia. First and foremost, I am a woman in long-term and sustained recovery. That means I have not drank alcohol or misused a prescription in almost 14 years. Thank you. I am the CEO Well, I'm changing my title to the CIO. The CIO of HardBeauty and the executive director of the HardBeauty Foundation. We are a primary peer recovery coaching practice that covers state line to state line for the state of Colorado. We employ right now 17 mamas who are in active and sustained recovery. So not only are we, but we also employ ourselves and have created a specialized practice with folks who are working with women who struggle with substance use disorders. I'm also blessed as a peer to be able to advise the state of Colorado. I am on the Behavioral Health Advisory Committee to the Behavioral Health Administration. And I'm also the only peer appointed by Phil Weiser to the Opiate Abatement Council for the state of Colorado.
Okay. Can you both please tell us about your experiences with shame or stigma when you were pregnant or parenting, when you were trying to navigate the healthcare system?
Yeah, when I think about that, you know, there's lots of things that come to mind, and there was so much that led up to the moment that I'm going to share about. When I was pregnant with my second child, I was in an incredibly lethal relationship. And my partner and I, when we met, both were really, really struggling with substances and got married really shortly after we met, probably maybe 2.5 to 3 months. I immediately got pregnant and really cut down on everything that I was doing. During my pregnancy, I went from 3 packs a day to 1 cigarette a day. I went from being blackout drunk almost every night to a total of 5 half glasses of wine, which I still really regret those. And from really using a lot of different substances and already struggling with opiates from a doctor, I got 1 prescription of Percocet for some really extreme back pain, but my husband took most of it. When I went in to deliver my daughter, it was a military hospital and a training hospital. So I don't actually think I knew any of the people in the delivery room, but there were 9 students learning how to deliver a baby. So there was a tremendous amount of people in there. During my labor, my husband was really, really upsetting me. And instead of asking if I need anything, everyone who came to check got angry with me because of his behaviors, because he kept trying to chew tobacco in the bathroom and he kept wanting to leave to go to the bar. But instead of supporting me, I was like really ignored during that time. And I understand there was 9 other women having babies that day. And because I had an epidural, like they could just kind of leave me alone. And they did. And a few hours after I had my daughter, he left to go to the bar so he could show off pictures. And I remember just being there all day by myself. And the only time people asked me when I felt safe at home was when he was in the room. I can't tell the person that strangled me, I don't feel safe around you, because he'll just do it again. And I remember when I told one of the doctors that I saw early in the pregnancy, I've cut down to 1 cigarette a day, instead of saying anything positive, it was, well, maybe you'll decide to quit for your baby soon. And then I was given a piece of paper about like a smoking cessation or something, but that was it. And after I had my daughter, I was way too afraid to ask for any sort of help, because I knew from friends, you know, she would just get taken away. So I waited a couple of months after having her till luckily he was arrested for domestic violence, and I was able to get out of that relationship. But being ignored the whole time when I was having a baby, when clearly my partner was struggling with substances, made me stay even more quiet.
You know, I'm a biracial and my father's Black, was segregated till he was 18 years old. My mother is a foreigner from the south of France. It was funny, I was driving down here and I had to pass the old Fitzsimmons building. And my mom, I was telling Tiffany, I said, I don't know what part of my story is part of that building, but I know somewhere in my very early experiences on this earth, probably within the first 4 weeks of my life, I was cared for in that building. My mother actually tells the story of having to go back to work at about 3.5 weeks, 4 weeks postpartum with me to go back to work. And honestly, that was my entire life with my mom. She worked very hard all her life to take care of us. So, part of what I never saw was self-care in a mother. I never saw her take care of herself or take time for herself. She sacrificed absolutely everything for us. And so when I had a baby, I thought that's what I was supposed to do. I thought I was supposed to sacrifice everything and everyone for that. Back then, 14 years, well, gosh, Jordan's 21 now. Ooh, that's a long time. I just became a Gigi. Actually, I'm a grandma last week for the first time. My 21-year-old, I remember having him and just feeling very much my mom, when I remember telling her, like, I don't know what I'm doing, Mom. She said, I don't remember. And then I remember the story of her putting me with someone else at 4 weeks old. And so I just imagined she didn't have a lot of time with me when she was little to be able to give me advice on what to do with Jordan. I remember when he was born that I was instantly scared for everything on the planet. And I had an incredible amount of fear show up upon me. I tried to go back to work when he was 6 weeks old, and I quit my job on the day that he was going to go back because I could not hand him over. 21 years ago, we didn't really talk about a postpartum depression. It wasn't even a thing, but I definitely know that that was my experience with my first one. And I continued to have babies one after another. I got married when I was 19 years old. Mackenzie was early. I remember a nurse that used to have to come and give me shots and so that I could keep her in. And then Jessie, I remember that as well. My hardest part for me was when Jessie was born. So I went to rehab. I had 3 kids. My best plan, I was like, okay, I'm going to go after rehab. I'm going to not have any more babies. I'm going to go get my tubes tied. And when I went to go get my tubes tied, the doctor told me I was going to have to wait because I was pregnant with number 4, 6 weeks out of rehab. I remember going to have Jessie. I remember being very scared. I was very open with my doctor the entire time because I had gotten rid of my opiate use disorder. I wasn't using opiates. I was so scared to do anything. I didn't even want to talk about an epidural. I had spoke to a woman who said she would be my doula. And that was the first time I had even heard of such a thing. I had my first 3 kids. No one ever offered me any other type of care or birthing experience. I think I remember seeing maybe some water birth ideas. I don't know. It feels so long ago. All these different options for having a baby. But I remember when Jessie was born, I was very adamant when I went in the hospital that I absolutely did not want any medical interventions because I had an epidural. I mean, I had a cerebral leak, a spinal fluid leak that actually catapulted into a Chiari malformation back surgery nonsense, which got me hooked on the opiates in the first place. And so I was very adamant in the hospital that I didn't want anything, but I had nobody advocating for me in that space. And on my record, it said that I had a previous opiate use disorder. And not until about 8 weeks ago, actually, did I realize and learn that you could ask for 2 different types of epidurals, one with fentanyl, one without fentanyl. And most women actually don't know that. I would have loved it to be given an option. And I know another woman too, is that it ended up kind of starting something again by giving that opiate to me. And I was able to not take that beyond the hospital, but I wish I would have known that. And the first thing that was given to me when I said I didn't want an epidural was, we could give you fentanyl. It was the only other option was given to me when it's on my record that I have an opiate use disorder. And when I don't want to have an epidural, the option is fentanyl. So the first line of defense most of my life has been opiate given. First thing that I've been given, even when I had back surgeries, I had a brand new baby, the first thing they offered me was fentanyl. First thing they offered me was Opana. I never got options for like other kinds of care or holistic practices. You know, I go into birthing rooms. I've been in 10 hospitals in the state of Colorado and all the labor and delivery places. And I see balls and swings and all these cool things that you can do to have a baby. But never were those an option for me. And so, you know, and the struggle of being honest about the alcohol use, this constant pumping and dumping, trying to nurse and be well, trying to maintain my own self, but also being told, that I have to feed my baby, and being shamed, right? Because I can't stop drinking and going to using formula and not accepting the fact that maybe I just can't stop drinking and encouraging my formula use instead of making me feel like I'm a bad mother for not doing that. Feeding my baby is responsible mothering. It doesn't matter how I feed my baby. If I choose formula, don't shame me for that. If it's the best choice for my child. So that was something I really struggled with. And so I went through this huge pumping and dumping mental overload to try to make that right when I should have just been, Raquel, if you need to formula feed, that's okay. Congratulations on feeding your baby.
Awesome. Thank you. Okay. So you had your pregnancies, you had your deliveries. Now baby is either in NICU or nursery or wherever they ended up. Would you mind telling us your experience in that situation and any interactions you had with your nursing staff or your healthcare team that either hurt your experience or benefited your experience?
So my first pregnancy, I didn't use any substances prior because I was not an adult yet. That pregnancy also had a lot of shame around it because I was still in high school. And I remember I'm a very small human, and the way I was laying on my back giving birth didn't work. And my son got stuck. And right towards the end, the doctor just reached in and grabbed his little head and pulled him out because he was stuck in a way that like it would have taken too long to get to do a C-section. And I was pretty out of it because they had given me Stadol because I didn't want an epidural. And I had been in labor for about 28 hours, so I was really tired. But they started doing CPR on him, and then they took him away. And I remember asking my mom, what baby did I have? Because I didn't know the gender. And nobody said anything. They just took him away. And I was waiting and waiting and waiting. And finally, my mom was like, well, I'm going to go find out. And she came back and she said, oh, they have him in the NICU just because he wasn't breathing and had CPR for 8 minutes. They need to make sure he's okay. And it was like 3 hours later that a nurse came back and was like, okay, we're bringing the baby back to you. I had no idea anything about this human that I had just brought into the world for over 3 hours. And nobody came back and said anything. And, it created a lot of fear in that moment when I already had so much fear. I had barely just got my driver's license. I didn't have my high school diploma yet. How am I supposed to care for this young human and then not getting any information about him? And it just would have been helpful if somebody had come back and said, hey, we did CPR on your baby because the baby was born not breathing and we have to take him to the NICU. You had a boy, congratulations. That would have been really helpful just to have informed consent on where my new child was going. And I have had positive experiences. I think there was so much trauma and fear surrounding the births of my children. I don't really remember any from the nursing staff or the doctors, but that doesn't mean that it wasn't there. It just means I don't remember it. But I have had doctors. It's funny because a lot of times now when I say I'm a person in recovery, please list opiates as an allergy on my chart, I do sometimes get like a look or a okay, but then I tell them what I do for work. Every single time the energy in the room changes, the person who I'm talking to goes, oh, that's wonderful. Tell me about it. So it's when I mention now I use my story to help other people heal themselves. That's when I get treated differently and I get treated more like a person.
I know. I don't know whether I love that or hate that, to be honest. Like, Because we're dealing, like, literally I'm sitting back here dealing with this whole issue on a cell phone of a mother. We've been really trying to get help who just cannot get care. And I just want to lose my gourd on that, because 34 weeks unhoused deserves some support, right? We're all sitting here and I'm thinking, gosh, I'm in this room. I bet you I'm gonna find something today. Watch me. So I'm putting that out there. But, for me, the NICU was my third child who at 2 weeks old got RSV. I have two stories for you about Jaden. Jaden got RSV when he was 2 weeks old. I rushed to the doctor's office and they tell me, Raquel, he's not breathing. So from the ambulance, we get rushed and we're doing old children's. So barreling down Colfax Avenue, I'm in the back of the ambulance. And they tell me they're going to turn on the sirens. He's not responding. So we go to old children's. We go inside. He is going to have to be intubated, and forced air machine. It's not working, and he's going to have to be intubated. I don't know what to do. I'm frozen. I actually remember that night being in the hospital and going outside and meeting my friend Krishana. Her and I went to high school together, and she told me, I remember that night being scared. I remember nobody kind of telling me what's going on. And nobody asked me if I needed support. And yes, I do know that in the NICU that baby is so very important, but really so am I. I'm that baby's mother, and nobody asked me. And I met Krishana in the parking lot, and she said, Raquel, I'm here quite a bit. I'm here quite a bit because my daughter got a terminal illness is why she's here. And I had no idea. And she said, Raquel, when I have a night here that's too much, you know where I go? Scooters. That's all it took. I go up the street and I go to this bar, Scooters. That's all I needed to hear. Somebody gave me a solution to the way I was feeling, and it wasn't an option to go to get some support, mental health support, or talk to a peer. It was the person in the parking lot who said, hey, Raquel, you should go to Scooters. So guess what I did? I went to Scooters. And I left my baby in the NICU. And I went over there, got completely trashed. To offset the alcohol I had, I called my cocaine dealer. He went ahead and met me in the parking lot, nice and convenient. And he took care of that part. So for 10 days, that's how I operated inside and outside of Children's Hospital. And nobody asked me. I for sure know that I smelled like alcohol. I promise you, vodka doesn't really go away. But nobody again asked me for 9 days. An opportune time to ask mama, how are you? What does support look like for you? Who's supporting you? I also had an active husband. There's so many opportunities. I feel like right then and there, I could have gotten support, and someone could have asked me. And the reason why I probably wouldn't have been honest is the same reason I'm the one who says you're going to take my baby from me, instead of offering me support that would be cohesive to me keeping my baby. And so that's an opportune time. I've also watched in the NICU, I support moms, and I've been to the emergency room with a woman who is very pregnant, who is very intoxicated, and watched how they treated my client. I step in those places. You will not treat her with disrespect. And I recognize, ma'am, sir, that this is hard for you to see, but I'm going to rub her back, and I'm going to treat her with kindness. And we're going to treat her with humanity, because the reality is treating her like that would probably get a lot better reaction out of her, because spirit speaks spirit. So I've never really dealt with an overly dramatic episode in an emergency room, but that's because I'm coming in, and I come in with compassion and kindness. And you're talking about a woman whose daughter does have fetal alcohol syndrome. And do you want to know what she has to go through to go to visit her baby? She wants to come and visit her baby. But you know what that requires? It requires an 1.5-hour conversation with me before she even goes into that NICU, because she has to talk herself into it, because she's afraid and knows the stigma that she will see when she walks in there. She knows, and energetically, the 40 conversations that have happened before she walked in. Oh, guess who's coming back? Hope she makes it today. I can't believe she did this to her baby. She walks in and feels every bit of that. So it requires an 1.5-hour conversation before she walks in. She goes in, and then I'm an 1.5-hour conversation when she leaves, so she can talk about how hard that was. But guess what? She went to visit her baby. And that is the point. Because of the stigma, we do a lot of coaching and working with folks so that they will stay connected with parents and mamas so that they will stay. And I watched her have her first child and go through that. And then I watched it again with her second child. Again, why? Because her first child had FAS. So guess what they assumed? That the second one would too. And the amount of pressure and what she'd have to talk to go to a doctor's appointment was horrible. We do it again. We have a mom we've worked with for 2.5 years. Britt has been a part of that it took so much connection and community to get this mama. I was in the courtroom when they took her first child. She had 9 months, excuse my French, to get her shit together after being unhoused for 10.5 years. The amount of expectations for a mom is tenfold what it is for a father to get well. And every time a mother goes to try to get well, we are talked for abandoning our babies. How dare you leave your children? There's not a giant cheering factor. Good job, mama, go get well. That's not what's happening. It's usually seen as we are abandoning our children. And so we had to work very hard. We didn't get this mama. We knew she was pregnant at 11 weeks. We could not get her into a hospital to see a doctor until her 30th. It took us that long so we could meet people like Britt and say, "Gay, we got somebody for you. I got a doula. And I promise you, she's just like us." Right. And then it was really amazing because the outside of that is when she had her second baby, guess who was in the room? 3 recovery coaches. That was it. She chose to have an experience that was very different from us. And she got to go home with her baby. And so success is in that, we get to do this, to try to help and support the stigma. And in the NICU space, I recognize I've got to do so much thinking about this, about if you only ever see a shaking baby, I understand why you would have the stigma that you have. I will be honest, I would have it too. But maybe if you spent more time with those of us who recover, so that you can see the potential and possibility when we are treated with love and respect and what happens, maybe you will look differently and care for that mama a little bit differently when she comes in.
Incredible. Okay, last question. What can nursing staff, NICU nurse, or nursery care teams do specifically to help support pregnant and parenting people who have been impacted by substance use?
So one of the things that really helped me in my healing, and a thing that we practice with pregnant moms for making it through childbirth, is breathing. When you are walking into a room and you feel that, oh my gosh, how is she doing this to her child? I know she's drunk. I know she's high, and you feel that stigma start to creep up, take 2 seconds, breathe in through your nose and release it out of your mouth. And remember that this mama is a person first. I know you saw that slide about person first language. I used to refer to myself as all sorts of horrible things: slut, drug addict, bad mom, stupid, all of those things. And really, I was traumatized, abused, in pain, terrified. And if somebody had come to me, taken a deep breath, and said, "Do you want to take a deep breath with me?" that actually helps tremendously. It helps your nervous system. It helps the patient's nervous system. And always remembering they're a person first. They might be a person with substance use disorder. They might be a person who is experiencing trauma. They might be a person who has all sorts of different diagnoses, and they're a person first. So whenever you go to refer to somebody, saying a person with, right? I am a person with things, but I'm always a person. And then inviting your patients to do things. I know it sounds a little bit silly, but in my recovery, I also found yoga. And what I noticed about yoga instructors is they invite you to sit on your mat. They invite you, if it feels safe, to close your eyes. They welcome you to do things. And even though when you walk into a room, there might be a bed and a chair, you could tell your patient, "I invite you to sit where you feel more comfortable." Tiny little things like that make a huge difference. And then relaxing your muscles of your face. I know when you're working, that's really hard to do, especially when you're worried, you're hungry, you really, really have to pee, right? It's like, and if I have experienced trauma and you come to me and you're squinting, immediately I am activated in my nervous system and I'm afraid of you. And I have no idea why. And it makes it harder to trust. So when you take that deep breath right before you walk in the room, think to yourself, relax my eyes, relax my face. That allows the patient to see you as somebody who is coming to help.
I love what you said about person first. Even those of us that have substance use disorders, I got sober in a very small community. I'm from the Aurora area. Grew up and got kicked out of every bar on Iliff Avenue. But I ran away from myself to Palmer Lake, Colorado, population 2,500, where there's only one way to recover and you speak one way. But we've really, in the last 5 years, have had to change the way we speak about ourselves, right? Like I have recovery junkie on my t-shirt, right? That's a play on words. But 6 years ago, I'd have called those who struggle with heroin use a junkie. I don't say those words even anymore, right? I've actually very rarely, I grew up in a world where I always said, hi, my name is Raquel Garcia and I'm an alcoholic. I've said that for 13 and a half years. And you hear me today say that I'm someone who is thriving in long-term recovery. I've had to change even my own language, and we're working on our own cultural changes so that we speak to each other differently. So I think language is really important. I think being brave and getting to know some of us. I call a lot. I do a lot of work with the Naloxone Project. I'm also vice chair of the Naloxone Project with Dr. Stater and with Rachel Duncan. And I get to work with Dr. Klee all over the state of Colorado. And I think what we have been able to do is I hope I've helped reduce their anxiety about working with us. And they've also helped me reduce my anxiety. I have an autoimmune disorder and was really mistreated for a while with mine because of my past substance use. And so what they've done and what even being here has done for me is it makes me a lot more brave. And I have reduced my stigma against you because believe me, if I'm really honest, I had plenty against every single one of you, especially about 2 years ago, because I wouldn't go to a hospital. Someone told me, well, I'm working so hard to save your life, Raquel. And here you are smoking, trying to kill it. As if all of the substance stuff, all the healing I had done didn't matter. They were so worried about the cigarette I was still smoking. And I didn't go to a doctor since till I met Dr. Stater. So he's really worked on that for me. So coming out, I tell doctor, I'm like, we're some great people out in the community. You can come outside of your hospitals. You can come outside of your doctor's offices. We're really cool. And we give you street credit. We do, right? Because if you don't know the answer, you can say, guess what? I don't know anything, but I got this girl, Raquel, ask Allison. She does it all the time. She's like, hey, bestie, in my cell phone, I got somebody I need some help with. And guess what? That's that client we're still working with today. We've been working with her since you called her because that's what we do, right? So we can help each other out. So that's where I think it's beneficial. We're actually doing that work right now, language. And then go back to motivational interviewing. And I love it because you said permission. I teach master level motivational interviewing, especially when it's talking about substance use disorders. And I get to teach that all at the state level as well as the national level for SAMHSA and the Opiate Response Network for the country. Motivational interviewing will be great if you just ask permission. May I? Can I be honest with you? Most people will actually tell you yes. Some people are going to tell you no. And when they say no, listen to them. When they say, no, I actually don't want to do that, don't keep going. Stop. It's giving you a space to stop and move forward. Going back to some of those just old school techniques of MI really will, because that's what we do with our clients. I don't force anybody into anything. So language, getting to know somebody, maybe going in your own family, asking, is there someone in our family that struggles with substance use? So you can find some humanity in it all. Language and permission. So those are the really important things I think that would really be beneficial for nurses.
Incredible. If you enjoyed your experience talking to these wonderful women, it's important to note that this training, the Stigma and Bias training, has small group breakout rooms with multiple representatives of HardBeauty. So you, your colleagues, the nurses who work on your unit and your floor can have these experiences in a small group where they can feel comfortable asking the hard questions and asking the uncomfortable questions.
Yeah, yesterday was really neat. Just I want to bring it up. Like, it was great because a nurse was nervous about, did I say this right? And I was like, no, let me help you. But like, but that's the point, right? Because what you don't want to do is nurses don't want to hurt they don't want to hurt the patient. And so you're not going to be brave where you might cause damage because of the heart of us. I wouldn't do it either. So creating small, safe spaces where we can say, did I say that right? I'm like, no, let me try that. How does this sound? And she's like, okay, we'll try that better, right? But that's the point. Otherwise, if we don't get together and have these brave conversations, they won't ever occur.
Can everyone give a big round of applause? Thank you.